field epidemiology in Africa started with the public health schools without walls, which started in 93, 94, 1993, 1994, 1995 in Zimbabwe, in Uganda, and Ghana. And they were an adaptation of the US Epidemic Intelligence Service, which began in 1951. Briefly, the EIS, or Epidemic Intelligence Service, is the structure that the United States uses to do public health. And a lot of the many people who have done public health nationally in the US and internationally are graduates of EIS. Indeed, I think 4 or 5 of the past CDC directors are EIS graduates, and several people around the world have done EIS. So when I went to do EIS in the 90s, I saw that in Africa we needed to adapt that model, but also blend it with what was existing as the public health schools without walls. Now, the public health schools without walls were actually led by EIS graduates. In fact, in Uganda, one of my mentors, Professor Mark White, started the program. Didn't start it, but was integral to the program in Uganda. And also other EIS graduates worked in the other programs in Zimbabwe. Not sure there was one in Ghana, but they worked on it. And the whole essence of EIS and programs such as that is that you can do public health in the field. It's like when you become a physician, you can't do medicine from books. You have to do it with patients. That's how you learn, learning by doing. So that's what EIS does. It's done it for almost 75 years, over 4,000 graduates. And that's what public health schools without walls were doing. Now, with the public health schools without walls, they also added in the component of obtaining a master's degree and a close relationship with the universities. And so that is something that we found attractive when we started the first FELTP, Field Epidemiology and Lab Training Program in Kenya for Australia and also. And we made sure that EIS, the applied learning in the field, working with the university, which we knew we could be blended so that we have a uniquely African solution that will be able to provide a workforce that could be high-end within the ministries of health or other ministries. Because as we all know, in Africa, if you don't have a qualification that the Health Service Commission or other commissions can use, you won't be able to get a job. So we did that, combined public health schools without walls, EIS, to start the Field Epidemiology and Lab Training Program in Kenya. So now, the other part of it, which sort of the reason why we did this, is because when I was working at CDC in the US, we were supporting Africa to develop integrated disease surveillance and response, which is the strategy that the continent uses for preventing, detecting, and responding to outbreaks. And we developed guidelines, we developed all tools, but it became clear to us that these guidelines will never be themselves. That we needed a workforce that would be able to implement a guidance. So for me, always, and even up till now, the driving reason why FELTPs in this continent, or FETPs in this continent, and the other associated programs are important, is so that you have a workforce that can prevent, detect, and respond to public health emergencies. FETPs and FELTPs are generally the same thing. The unique component in the FELTPs is that you are adding public health laboratory scientists, veterinary doctors, and other groups of professionals that are needed to prevent, detect, and respond to public health threats. So that's where the unique L part comes in. Now, the regular MPH, which I did before I did EIS, is of course a great program, and many people have done these things with the regular MPHs. And an MPH can be in multiple disciplines. There's MPH in informatics, there's MPH in epidemiology, there's MPH in infectious disease, international. So MPH is a broad encompassing qualification. But field epidemiology, on the other hand, all the learning is in the field. So when I finished, and several of us who came from where I went to, finished our MPHs and joined EIS, we found that this is like finishing medical school and doing internship. We're doing residency, because now you're bringing what you learned more or less theoretically into practice so that you can implement it. And it's a unique set of skills. I remember when we finished medical school and we went to do internship, we knew we were doctors, but you learned how to be a doctor when you did your first operation and realized that what is in the book and what is on the table are not even close. So working within the field is where the MPH and the FETPs or FLTPs differ. However, in Africa, because we don't have so many resources, we can't really say, okay, do MPH and then go and do 2 more years of FETP or FLTP. That is not fair. So what we try to do is do some trade-offs where we are combining the MPH type rigor from the universities that you really have to pass this class and this with the field component from EIS to create a blended program that you could do over 24 months and come out with, yes, some trade-offs, but at least be able to do what we intended to do. When we started the FLTPs, after a while, we set out what we defined as critical outcomes. And there are 5 or 6. So we said, if what we are doing in a country or what the country is doing, it's not really us, what the country is doing works, then we should be able to see these fruits. Just like if you plant an orange, you are not going to see potatoes, can both see oranges. So the fruits of a functioning FLTP are about 5. One is that you have a robust public health surveillance system, which will begin mainly with infectious disease, but then also get into non-communicable, and other surveillance systems, which, by the way, kill more people than, of course, COVID killed a lot of people, but people are dying of hypertension, strokes, road traffic accidents. All those things require surveillance so that you can measure them and respond to them. So if the program is working well, one critical outcome is robust public health surveillance. Along with robust public health surveillance is prompt, effective response to public health emergency. So surveillance and response go together. And then the third one would be culture of evidence-based decision-making in public health. So that whatever you do in any of the programs that are in the country, you use evidence, not just gut check or because somebody did it before. So you're using evidence-based decision-making. And then we also pointed out a strengthened workforce comprising the people who have done the advanced program, the 2-year program, and then the associated other short courses now called frontline or others. And actually, when the way we conceived it is that there will be people doing 2-year programs, there will be people doing shorter programs, And even there will be people doing online programs so that everybody knows that you need, this is what you do to prevent, detect, and respond effectively to public health emergencies. So it's not only for the 2-year people, although they are the ones doing a lot of the leadership and the strategy, but all these other programs and all these other things are involved. And then the fourth one is all these things should be showing a reduction in morbidity, that is illness, and mortality, that is death, in the country. That can be attributed to the fact that your program detects diseases faster, you respond better based on evidence, so less people are falling sick and less people are dying. And then the last one would be the networking within the advanced, the intermediate, the frontline, and also other people who haven't done the FATP within the country and outside the country. So we defined these, we wrote them up. I'm happy to give you those references. That's what needed to happen. Now, we also added one other thing, which is sometimes we forget about it. That these things can only work if the country also creates structures in which to plug in these trained people. Just like if we had a program training car drivers. We have so many car drivers, but no cars. Or cars, but no fuel. Or roads, and we know about the roads, but so we thought that countries would develop these structures. And indeed they're beginning. National Public Health Institutes, multi-disease surveillance and response units at the district, lower and other levels, so that as we train this workforce, it's plugged into places where they can do that work. And we defined all of this and wrote it all. And so as bigger and bigger outbreaks come, COVID came, you saw what happened even in the US where I live, lost over 1 million people. Some countries did better, some countries did worse. But we knew before COVID that another zoonotic illness would come because we had seen Ebola in West Africa. We wrote about this and pointed out that a continent and others needed to be prepared. So COVID came and went. Now we are seeing Mpox, and we will see something else. And that goes back to my earlier point whereby if you are a purist and you just say we only need to train epidemiologists, well, the old sort of not old, but some people believe that FATP is only for epidemiologists, the others are not necessary. And then you get Mpox, or you get Ebola. You, the epidemiologist, has never seen a vet, don't know how the vets work, okay? Or you don't know how the lab works, or you don't have colleagues in that system. But then that is sort of a little bit short-sighted. So if it involves as a holistic network of people trained to count, divide, and compare in the same way, but working in different areas that are needed. For instance, now climate is coming, right? You are told, the rain is going to take us, or the sun, or whatever. But you need people who know about the environment, but also then know how to do the epidemiologic competencies and have trained with epidemiologists so that they can all work together. So getting back to this is a longish answer to your question. I think that the full network of people who are trained in the same way, some people have done a fraction of what the others have done, commensurate with what their role. So the people who are doing the front line are able to work with the people who are doing the advanced and the other programs to fully staff and operate the public health surveillance systems. Again, the African model is based on trade-offs, as we said. You don't have a lot of money, you don't have a lot of time, but you have a big need. So you try to plug in as many things, like a lorry carrying as many people as it can, safely, of course, to move along. So in these days, as we know that in mpox is zoonosis, we are going to see other zoonoses over time. It makes sense for the people who are doing, the physicians who did epidemiology or other health scientists who did epidemiology, to know that when I talk about this rate, and I'm speaking with the veterinarian, they understand the same rate that I'm doing, okay? And vice versa. And the veterinarian says, you know, the attack rate in animals is this, then the physicians also understand that. And then we are taking the right specimen to the public health lab, okay? And the laboratorians understand the need to make the right diagnosis in a timely manner. If we add in the environmental health scientists, we understand how to reduce the attack rate on all levels, so that when you're talking about the same thing. So that's one of the sort of the uniqueness and what we thought that we would see. But also, if you're looking at the advanced program, the people who have trained together now are in leadership in these areas. So when you say, okay, Ministry of Agriculture, we need A, B, C, and D, you're talking to the fellow leaders or people who can make decisions. But also in the field, when you need to go, I remember one of my friends, who I will not mention, or when they went to one of those Ebola outbreaks and they had to go and get specimen from a monkey, he could not get anywhere near the monkey. I think it even beat his glove or something. But the vet knew how to get the specimen from the monkey. You know, so those relationships, particularly in this area where we know that another big zoonotic disease will come, it's not that it won't come, it will come. So having already these networks between people who are in different professional areas, but who are trained together, then you really have a team, sometimes even a virtual team, that can work together. Conversely, in that, of course, we are all worried about the communicable diseases, but non-communicable diseases kill far more people. Maternal deaths, road traffic accidents, floods, all these other things. Again, people who know that the rate, the incidence, the prevalence, you're counting the same things and being able to make the same decision. I think for me was what was attractive with this whole FELTP model, where the L is just standing in for all the others that you can add in. And I still want to advocate that those who see that, oh, no, you don't want those other days, then it's not going to work. It will not work. The epidemiologists can do everything on a calculator, right? But what are you calculating? You need to be able to know what's happening in the lab. You need to have colleagues in the lab that can also calculate the same things, right? They usually are actually more important, because for us, on this other side, the lab has these three phases. When you're talking about public health lab surveillance: pre-analytic, analytic, post-analytic. Now, the pre-analytic phase is where we collect specimens and things like that. But if you collect the wrong specimens, the lab won't tell you the right answer, right? And so if you all are trained together, but of course everybody goes and pursues their profession. I think where people get worried is, we are trying to bring more people into the epidemiology field, or we are trying to get into the lab field. No, everybody follows their own professional path, but you're trained together so that you can work as a team. Even in the most advanced countries, those programs struggle every year for funding. So people have defined sustainability in three broad buckets. political sustainability, financial sustainability, and programmatic sustainability. So political sustainability is, at least for the FLTP or FLTP movement in Africa, is very, very important. Connections at the highest level, ministers, even higher, to lead the steering committees so that appropriate resources and appropriate plans, career paths are thought about. Okay. And that, of course, is a challenge. It's an ongoing challenge. There's never enough money or time. I mean, you either have more time or money. There, people have talked about it. So that issue. So, but if you have the political will, then you can address these issues. And I think COVID was an opportunity which I hope programs used to bring that. Now, finances are always going to be an issue. When these FELTPs were started, most of them were started with external funding. And of course, the external funding can't be foreign. Nobody will help you foreign, especially if it's your problem, right? You are the one with the problem, but you want somebody else to help you. You know, you are asking me to come to your house to buy you food, right? You are the one who is hungry, I'm not. So there are many metaphors for this. But I think there are certain ways to look at this. And again, that's where the role of the universities becomes really critical. Because all countries have worked out how to train university students. They take loans and themselves or whatever. So again, when you link, and this is a university course, then at least the training sustainability is there. So the people who are running the programs have to always insist that in as much as we like internship and residency for physicians, the field for the field epidemiologists is in the field and is as important as the other component. And so that's where it is the programmatic sustainability, making sure that those components are taken care of. So those are the three challenges. Now there's another major challenge which when I was actively working on this, I saw, but now I'm not actively working on it. Career paths for graduates are really, really an issue, and they need to be taken up and thought about, because it doesn't make sense to train people who cannot get jobs. It doesn't make sense to have drivers who cannot drive, who have no cars. They will be taken up by the world. They will go abroad, they will go to other places, or they will even go back to where they were. So programs and their ministries where they are linked should always focus on career, making sure that where are the people that we trained. One country which I want to mention came at it was they only take you if you have a job that would be within the area that we need. So if you are working in a public health lab and we need people in the public health lab, and they train the people in the public health lab, and then they'll be promoted. Or if you are working in the district and we can, that kind of issue. But also there could be explicit public health careers that are defined, developed, funded. Because as we saw with COVID, we're just a few weeks away from a huge outbreak that will spend all the money that we are saving, because so it's very expensive, we are going to spend a lot of money, but you will spend it responding, actually 10 times as much, trying to control an outbreak. It's like having a fire extinguisher vis-a-vis waiting for the fire to come, right? And then you run around and, you won't even know what to do. So this preparation of getting these teams, training them and making sure they're in these jobs is like having a fire extinguisher or having flame redundant materials in your house. So that when the fire will always come, this is one point which some of our audience may say, oh, why are we still having these outbreaks? there will always be outbreaks. But once the outbreak comes, if you have the team, they will detect it quickly, respond appropriately, and it won't burn down the house. There will always be a fire. But if you have a fire extinguisher, you extinguish it before it burns down the house. So that's where that mpox was there will come. Other diseases will come. But because you see the first 2 or 3 cases, contain them, then you won't get more cases. So the main trade-off we did was a time trade-off. Because if we really wanted to do a degree and a 2-year fellowship, then you're talking 5 years. I don't know how long them PhD programs are. Maybe they're 3 years or 2 years, I do. So, and then the experiential training requires about 24 months with some other issues. So instead of 5 years or 4 years, we compressed it into 24 months. So there are trade-offs. There are things that the field epidemiologist may not know that the guru in MPH knows, right? But for this continent, when Ebola comes, the guru in MPH is heading this way, the field epidemiologist is heading towards, right? And so that's the issue that we are trying to do. Now, obviously, once they have worked for a bit, they can go for whatever more training, get PhDs, become out. But we are training a public health workforce for a task. Not to remain in the library and read deep thoughts and think about books and theories, but to go and prevent, detect, respond effectively to hydrocarbon emergencies. That was the task. And in Africa, that was IDSR, which we developed. And even then, even up till now, yes, the countries, if you look at the COVID responses on the continent, countries with fairly good IDSR systems did fairly well, given all the things that the continent never had. Okay, so that system, that IDSR system has served us well, but it requires people to do it. And one of the cadres of staff to do them are the FE, LTP, FETP graduates and the associated courses. Me as one of the founders, I'm hoping that AFINET remains strong and encourages the member programs to continue being true to the mission. We need qualified staff at various levels in various disciplines to prevent, detect, respond to public health emergencies on the continent. So that's, if you brought me out and wheeled me in 10 years from now, I would like to see that. It's not going to be easy. It's simple to say it, but it's not easy to. It will require all the things that we talked about in terms of
sustainability on the different fronts.
In the different areas. But one thing is true. There will have been more than one major zoonotic outbreak on the continent. And it could be as big as COVID or something smaller. But I would like to look at a situation where that these FELTPs will have blunted the impact of whatever zoonotic outbreak could have been. That they've done what we used to call, we still call a left shift, whereby you detect earlier, respond better, so that there are less cases and less deaths, and that countries will be valuing this contribution from these people with a specific set of skills that can prevent, detect, and respond to public health emergencies. One of the things that I think keeps some of us going is we teach a lot. So teach somebody. It's like, evangelizing. Keep teaching, remain involved, in whatever level you are able to be involved. And that involvement may be really on the front line, the people in the ministries of health who are leading and doing these things, all in a small way. That even in your own area, you can see, you can look at data and come up with something that you can respond to. Of course, as I've said, we sometimes think that field epidemiology is only for infectious disease. It is not. It is not. It is not. In fact, going back to the 10-year thing, we are going to find that these non-communicable diseases will have become a major, major problem. Lifestyle diseases, all these things. And again, any field epidemiologist can contribute in any way possible, remaining linked to the network, teaching where you can, and helping when required to address public health problems. And they will not always be infectious. In fact, yes, zoonoses will be here, around. We are very scared, but even as we speak now, I don't know how many mpox cases like here in Uganda. Maybe, I don't know. There are many, but there are not very many. But if you go to the hospital and see stroke, hypertension, road traffic accident, mental health problems, all these things are public health conditions that can be counted, that we can find out their effect on the society and work out responses based on data. So, as you know, I was one of the founders of Jeff. We are very proud of it. I still have my t-shirt. I wear it once a week, wherever I am, but it's getting a bit smaller now. You will edit that out. But one way to help spread the message is by communication. The podcast, one way of communicating. But I'm a firm believer that publications are critical in your public health life. In fact, when I do some of these courses on this, I challenge the classes to think about their chronological age and the epidemiological age, and whereby at a certain level your chronological age and your epidemiological age must be the same. And then at another level, your epidemiological age must be much, much greater than your chronological age. Meaning that women who are always 21 have to have at least 21 publications, right? But as you grow older, you find, and a lot of the people we admire in public health take the time to distill the message and communicate it in a journal or in a journal article. Now, in Africa, we've lowered, at least in the Affinet space, we've lowered the bar. There is a journal which is in-house. So it has to be used. One, as a training venue for residents to put in their articles or graduates to put in their articles. But two, as a communication venue for the network to lay out policy position or opinion pieces. So what I would hope, I haven't recently looked at it, but I would hope that the senior field epidemiologists and directors will be writing opinions. This is what I think about this. This is what I think about this. In fact, even as one low-hanging fruit, after this series of podcasts, you could summarize them in articles, because people won't have, people may never have, we hope they will have, but they may never have 45 or 50 minutes or whatever to listen to. But if you've written a paragraph or two on an issue and put it in your own journal where, there's an opinion, or these are the results of something, Like for instance, I pointed out an article we wrote when we had a meeting on FERTPs 10 years ago. So we got what we talked about and distilled it into an article, which is still relevant 10 years later. But a podcast, however great it is, may not be relevant 10 years from now. So JIF is a venue for everybody, not only the students. The students, yes, it's a requirement, and now there wouldn't be anybody who says I don't have anywhere to publish. With an in-house in Africa journal. And then also the other senior people should be invited to write opinion pieces on various things. So somebody can talk about environment and environmental health issues, and another one can talk about lab, another one can talk about that. And those are opinion pieces which are read by the world, which then communicate a certain position. So yeah, I think it's great. It's now 5 years, getting to 6 years. A 6-year-old child can interact. So this is the time to start saying, using this as the mouthpiece of what the policy direction that Affinate wants to lead in the continent and in public health